Today's webinar, which is entitled, Let's Talk, How to Create Patient and Community Partnerships to Enhance Research. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions, the Healthcare Systems Research Network and the Claude D. Older Americans Independent Centers, or Pepper Centers. The Aging Initiative is led by Dr. Jerry Gurwitz at University of Massachusetts and Myers Primary Care Institute, along with co-PIs Elise Adams and Jay Magaziner. My name is Heather Whitson. I'm an Associate Professor of Medicine and Ophthalmology and the Director of the Duke University Aging Center. I'm part of the Aging Initiative Dissemination Workgroup, co-led by Leah Hanson at HealthPartners. Before we get started, I need to cover a few technical details. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. So unless you are logged in as a host or a panelist, your line is muted. However, we welcome and encourage audience participation using the QA or chat features of the webinar software. If you are in your Cisco webinar portal, look at the row of circles across the bottom center of the screen. Click on the chat bubble icon until it is highlighted blue. If you have questions for our speakers, please click on the Q&A tab on the right side of your screen and type into the Q&A box. Leah and I will keep an eye out for those questions under the Q&A icon. As time permits, we will read questions for our speakers after the presentation. If you have technical or logistical questions, we ask that you submit those using the chat box that is above the Q&A box. Please make sure that you are identified by either your name or participant ID so that our webinar hosts will be able to help troubleshoot any problems that you're having with audio or other issues. With the chat function, you can choose whether you would like your comment to be visible to all participants, or you can choose to send to the hosts only. We want to extend a huge thanks to the hosts, Catherine Anzoni and Chris DeLude at the Myers Primary Care Institute, who do amazing work behind the scenes to make these webinars possible. They'll be monitoring the chat functions today to help with any technical troubleshooting. And now, I would like to introduce today's speakers. Libby Hoy is one of our speakers, and as a result of her years of lived experience as a cancer patient and as a family caregiver for her 3 sons living with mitochondrial disease, Libby Hoy founded PFA to implement the infrastructure for authentic partnerships with patients and families in all healthcare activities, including research teams. Our other speaker is Dr. Jane G. She's a practicing general internist and an investigator and assistant professor of medicine in the Division of General Internal Medicine at the University of California, San Francisco. Her overall research program aims to reduce health disparities and promote health equity among multi-ethnic and linguistically diverse older adults by developing and evaluating innovative, patient-centered interventions. In her work, she has engaged stakeholders, including patients, families, and community organizations in the design, implementation, and assessment and dissemination of research, including most recently with the Diverse E-Cohorts Project, an academic community partnership between 4 community organizations and UCSF to address the lack of minority participation in studies that use online mobile technology to recruit, collect data, and deliver interventions. Without further ado, I'm going to turn it over to today's 2 speakers. Libby and Jane, are you with us?
We are. Hi. Good morning,
Hi,
everybody. Hi.
Good morning or afternoon, depending on where you are.
Oh, right. There's that. So I'll kick us off. This is Libby Hoy with founder and CEO of PFCC Partners, and I'm really delighted today to join Jane and present this conversation. We really do invite everyone into the conversation, putting your comments in chat and participating where we have participation points. I think the model that we're setting here is the true partnership and the potential for partnership between patient and family representatives and the research community. So just a little bit more about me. I started as a family caregiver when my mom was diagnosed with stage 3 breast cancer. When I was a teenager, I became a family caregiver for her, very uncertain of my role in the healthcare system. Shortly after she passed away, I had my own family, and I have 3 sons living well with mitochondrial disease. And then in 2016 was diagnosed with stage 3 salivary gland cancer myself and went through radical neck dissection and concurrent chemo and radiation. So I really have spent a tremendous amount of time in the healthcare system and more recently, more time in the research world, and just really have that perspective with which to inform the discussion today. So with that, I'll pass it off to Jane to further introduce yourself.
Thank you, Libby. Looking forward to giving this presentation together. And thank you, Heather, for the kind introduction. So I just want to share that my roots is working with the community, especially with patients and families. Started off when I was a medical student, I was a community organizer working in Asian American communities to highlight health disparities in their populations. And so I want to say that for those that may be on the call that maybe earlier in their training, sometimes the work that we do earlier in our lives really inform the work we do professionally. So engaging stakeholders is certainly a passion of mine. So I'm happy to be on this call today. So we want to kick things off with a poll. And you'll see that to the right of your screen where you have an option to pick A, B, or C. And I'm going to wait a moment for our host to have that up. And then we have 30 seconds to complete that. And then we'll check throughout for any comments that you include. And Libby, I think I love when you share your story. And I was wondering, how did you come up with the idea to start with your organization, and how was that whole process like?
Well, we were, really when the boys were growing up from the time of birth, they had 5 to 6 different specialists following them at any one time, times 3. So we needed a team approach to care, and I started to learn about patient and family-centered care from the Institute for Patient Family-Centered Care, and really saw a need to bring that focus here to the West Coast. So that was sort of the reason for us getting started. And we are a large community of patients and families who are experienced in partnership in the role of advisor to a multitude of activities across the healthcare continuum, including, of course, research.
Thank you, Libby. So now we have the poll results to the right, and it looks like the majority of our attendees today have some experience. So we invite you to share some comments or experiences throughout the conversation we have today, and that we can all learn from. And then we have a few experts here who have extensive experience. And so hopefully we all can have a conversation today to build our expertise in this area and have research that better engage patients and communities moving forward. So I'm going to start off with sort of an introduction to what is stakeholder engagement. And when I think of involving patients and community members in our research, the broad umbrella is stakeholder engagement, where we involve individuals, organizations, or communities that have a direct interest in the process or outcomes for a project, policy, or research endeavor. And I like to think of this as an iterative process, and Libby, you can comment as well, where we each acknowledge that each party has knowledge, experience, and experience, and that we come together to create shared values, interests, and mission. And we oftentimes, I think, in the process of Libby and I creating this presentation, having a very clear and effective decision-making process and communication, as well as valuing each other, using strength-based communication is an important part of this process. And when we created this presentation, we talked a lot about different perspectives that we each brought. And so acknowledging and building on the strengths and interests of each of the stakeholders can really help the process to implement actions for change. So who are the stakeholders in research? And so many of you might have been doing research already with patients and families, but may also be doing research with other parts of the healthcare whole ecological system. And so that may be health agencies to help keep older adults back in their homes, health insurers, public health departments, as well as employers or faith-based organizations. So for the purpose of today's webinar, we're going to focus our conversation mostly on patients, families, and caregivers, as well as community-based organizations. And there might be also organizations that we're missing as well.
Thank you, Jane. And I think the way that you laid that out and the potential and opportunity for multiple stakeholders to come together and really have a voice in the research is the opportunity that we're talking about today. And I think we've seen patient-family engagement really take off recently, and I'm delighted to see that I think it's 56% of you have some experience engaging patients and families. I would say if we asked that question, even 5 years ago, that percentage would be a lot lower. So kudos to all of you on the line that are moving in that direction. And, I've just met so many great researchers like you, Jane, who are very interested in engaging the patient and family perspective in your research. And today we just have this opportunity to talk about, how do we do that? How do we really dig in? And so with that in mind, while I set sort of that national stage, I'd love to invite folks on the line to just chat in. And I think the chat box, if you hover over the lower part of your screen, that'll pop up. I'd love to have you chat in. Specifically, how have you engaged patients and families in your research? Was it in the planning of your research? Was it in the dissemination? Which activities did you really get them involved in? We really want to learn from the wisdom of the crowd that we have here on the call today. So please chat those in. So yeah, it's amazing. Since I started PFCC Partners in 2010, really the concept of partnership with patients and families across activities in healthcare really has just exploded. I mean, the landscape has just really broadened into all of these activities. And I think a little bit of personal perspective on that, I have served in the role of patient-family advisor since the mid-90s. And we were super excited if we got to comment on the color of the paint on the wall in the hospital. That was about the extent of our engagement. And now we're doing all these amazing things where we are being brought into folks like the National Academy of Medicine who have engaged patients and families to develop the framework for meeting the goal of a person and family-centered health system. And so what that means to me and what it means to our mission here at PFCC Partners is that it's not about me and my family, but it's about every patient and family member having the opportunity to participate not only in their healthcare, but in the system design itself, and be that research design, be that policy design. Patients and families are emerging into all of these activities, and it really is fantastic to see. So no longer am I really kind of beating the drum that this is a good idea, but we're getting to have these conversations like we're having today about how do we do it? How is that most effective? So I wanted to share this framework from the National Academy of Medicine. Full disclosure, I'm very partial to it because I was part of creating it. So, but I think it really helps us to look at the sort of 10,000-foot level of the health system and how do our care and practices relate to our research and our policy, and how do we come together kind of to move the culture to a more person and family-centered culture. And so I want to pause there and as I'm talking this language out, clarify for me, a person and family-centered culture is kind of the model of care where we can be full participants in all of the activities that build our health system. And whether that be my own care relationship or policy efforts or research efforts, quality improvement efforts, measurement efforts, that we all have that equal opportunity to participate in those activities. And I know Jane's going to hit on equity a little bit later. Certainly have a long way to go there, but this is sort of the opportunity. I want to call attention on the larger framework here of the gray circle around the edges. We have to continually learn, to really breathe the life of a learning health system. We have to continually evaluate how we're doing and where those opportunities not only to improve, but where the gaps are in knowledge so that all of you who are doing research can fill those gaps. So this is why I really like this framework, is because it's inclusive of all of the stakeholders that Jane mentioned just on the last slide. Next slide, please. So, and this is a kind of a drop-down menu, and I apologize for the tiny print, but you can find this piece of work, the framework, on online following. But I want to draw attention, to the different components. So we have leadership and levers for change over to the left, structures, and this is kind of the meat of how do we build this person and family-centered health system. We have to create connections. We have to practice things differently. But we also, under practices, have to engage patients and families in the research activities so that we're moving the health system in the direction that the people that are using it are actually influencing it. I think that we've, as I mentioned, my own journey, I think we're really moving the ship on leadership and installing those levers for change. As I mentioned, the National Academy of Medicine themselves have created this framework. So we have some of those levers and change for place. In the research world, we've got great examples like some of the contributions those of you are putting into the chat box. That's fantastic. We've got patient-centered outcomes research, which is really leading the way in how we engage patients and families effectively in the research world. So looking toward all of these components to bring together again and move the health system to a more person and family-centered. So I mentioned that patient and family-centered care really being the model, or as I refer to it because I'm simple-minded, the noun. Then patient-family engagement becomes the verb. It becomes the action. How do we build that model through partnership with patients and families? And as I was thinking about this, we're really of the mind that patient-family engagement is an overarching strategy for whatever outcomes we want to get to. And so, again, be that knowledge outcomes, be that care outcomes, or be that system change outcomes. And as I was preparing for this and after my conversation with Jane, I was thinking, gosh, what would happen if all of these other areas really employed patient-family engagement, the research world didn't? What would that look like, and how would we create this disjointed kind of health system that's relying on the knowledge from research, but that area has not engaged? And that kind of made me start to think about the potential and the importance of engaging patients and families in research. So before we go to the next slide, I just wanted to take a look in the chat box. Oh gosh, you guys have done lots of great things. Acquiring consent. Great. Okay. Providing letters of support and grants. Fantastic. Participating in a workshop. It's led to measuring impact. Great. Fantastic. Those are all fantastic activities. I appreciate you contributing. If we could go to the next slide, please. We're going to have you guys do a little bit of work, get that chat box ready to go. So we're going to do a force field analysis. For those of you who haven't done an activity such as this before, we're going to look at what are the driving forces that are really, can you click to the next one? I'm not sure which one we're doing first. Thank you so much. What are those driving forces that are pushing us towards engagement? Maybe it's funding sources, maybe it's new policies, maybe it's emerging technology that allows this kind of partnership and research where we haven't had that before. So I really want you to think broadly about what are those driving forces that can help you or that can be those levers for change for you in your research world. What's going on, be that in your community, your academic center, what are some of the things that are really driving you towards participating on this webinar today and learning engagement practices? So I'll wait for folks to respond in the chat. Jane, do you have any ideas about what might be, contributing to this momentum?
I think, with the creation of PCORI, that acknowledged a lot of the research community was doing with communities and patients and families. And I think for researchers, they're trying to build a sustainable, advance their work while building a sustainable academic career. That certainly increased, I think, thought about using PCORI as a funding mechanism. I think for myself, for me, it's a big equity issue where, our society here is moving towards majority minority, but our healthcare system yet doesn't reflect that. And some patients, may not share the same culture, race, ethnicity, or language. And so there are a lot of opportunities to involve them to create processes, answer research questions within our healthcare system. Just like you said, looking at the prior slide, what if all those elements involve patients and families? Wouldn't our healthcare system be so much better?
Right. Well, at least it would be really meeting the needs of those that it needs to serve, right?
Yeah, exactly.
And I think this whole engagement opportunity has, movement rather, has so much opportunity to contribute to equity in a way that, we just desperately need and don't have currently.
Yeah, I agree. I would also like to acknowledge there was a question in the box from an earlier slide where the participant says, I don't always think of people that I work with in my research as patients. I think I consider them as family members. Not sure if that impacts how we engage one another. I don't know if, Libby, you have any thoughts about that?
So I'm just trying to get back to the question. Could you read it one more time?
It says, I don't always think of the people, and you can see it in the Q&A box on the right tab.
Yep. Okay. Now I see it. So that's a very interesting question, and I love the intention behind it, because I think where it's leading is a closer connection and a more balanced approach to partnership that acknowledges people's lived experience as having value in the partnership in a similar capacity as the experience and expertise of the researchers. So I think that underlying intention is really positive, a very positive thing. I think where we want to be a little bit careful, and one thing that I've seen us sort of slipping towards is a movement away from patients as contributing their lived experiences. And so maybe it's persons or maybe it's community, and that's a good thing too. I don't mean that that's a concern. Where we get into a little bit of muddy water, I think, is when we engage people of very similar backgrounds and very similar experiences. I'll give you a concrete example. We see this when people are engaging advisors onto hospital board of directors. What we often see is somebody say, well, Bob came to the emergency room 2 years ago, so that makes him a patient as well. Or he can be that dual kind of focus. And I think we can. I'm not saying that you can't. I'm just suggesting that yes and, right? Yes, that person might make a great contribution, but we really need to have patients with lived experience in a particular disease state and that are affected by a particular policy or that are affected by, something that we're researching. That informs from a different perspective that we can't always get from folks serving a dual purpose. Does that make sense?
Yeah, I totally agree. It's sort of like, as a clinician, sometimes taking off that hat and seeing something from a perspective of being a human being or also a person that has a similar, condition or experience. So I definitely agree.
Yeah, and I think that has great value again, but I also think that that and the perspective of a person from our community or a patient who's had that lived experience. It's a little like, when we hire someone here at the organization, we always say, gosh, that first 6 months, we want to take advantage of your objectivity, right? You haven't seen our processes before. You haven't seen, it's just a super fresh look. And so it's a yes and that individual who has no other connection to your work other than being a patient as well. Great.
Thanks, Libby. Great question.
Yep. It was a great question. Let's see. Changing population in the U.S. So I'm sorry, I didn't have my Q&A box open. I was looking for the chat. So in response to those driving forces that are moving us towards it, the changing population, aging population, absolutely. Fantastic. Am I missing anything else in the chat box? No? Okay. Then let's move on. Well, before we go there, maybe we could think about some of the restraining forces. So what are some of those obstacles to engaging patients and families into your work? What are those things that we have to sort of overcome to create meaningful and high-value partnerships?
So maybe I'll start while we wait for the Q&A or chat box to fill with some comments. One thing from my perspective oftentimes is while there is more funding now for stakeholder engagement, there's also the barrier of getting funding, right? And so right. So sometimes the work in preparation for a project that involves stakeholders, that work is unpaid until the grant is received and then the funding. And so that creates a sort of like a mismatch of what needs of our, community or family partners are, in terms of wanting to compensate for their time and expertise. And so I think that is a restraining force, sort of the existing system, the research paradigm of how we fund research and how we engage with partners is a big challenge.
Yeah, certainly. I think the question of compensation has come up almost on a daily basis now in terms of how do we look at that. And I know we're going to touch on this a little bit later, but again, that connection from compensation to equity, I think, is much closer than maybe many of us had imagined. And so, like you said, with the research paradigm being that you fund and then do the project, then how do we compensate for those activities and preparing when we're talking about moving engagement upstream? And I think that's a very real challenge. I don't have a perfect answer for it, other than there are a lot of people out there who are interested in partnering even without compensation, or who will invest with you, for the long haul. Let's see, time, childcare, caregiving, funding, power dynamics, all of those, great. Thanks, Janice. Cultural and socioeconomic factors that interferes, right. So I think that's those last two kind of comments. It's really tapping into some of the burdens that we need to figure out in how we do meaningful partnership and research. It's not that we've got this all nailed down, but I think what it's going to take is some real innovative thinking as to how we engage with people that look differently. And, maybe it's not a monthly meeting. Maybe it's a series of phone calls or emails. Maybe it's, a focus group here and there, or maybe there's lots of solutions out there that I can't even imagine. But I think that the answer is going to lie in that we have to do things differently. And most of it is it's really going to require us to flip our perspective of bringing patients and families in versus going out and getting to patients and families where they live. And Regina Greer-Smith is a phenomenal patient partner, has done years of work with PCORI, and she always tells me, Libby, you can't bring disparate populations in. You have to get out there, and you have to have someone from within that community to be that linkage. So I think we're going to have to build different partnerships, create different relationships that can really help us to leverage how to get to folks.
I'll just add, Libby, is that sometimes, as the researcher or as the PI or someone, part of the main part of the research team, we feel inclined to want to engage with community partners as the face of the research team. And oftentimes, as you mentioned, if we don't share the same language or the same culture or have a shared experience, sometimes that's not the most strategic approach, right? And so I think it's thinking differently about some of these challenges. All these barriers are opportunities for positive change, right? And conflict is not always bad. And so I think these are all things that we're all trying to work towards to address matters of equity, especially wanting to include those from cultural, social, economic backgrounds that are different from ours.
Yeah, I think, and I would encourage folks not to feel like they have to solve the problem in isolation, right? You can have conversations, go out into the community and meet with organizations that, promote or support those communities. I'll give you a quick story. I realized that the Patient Family Advisory Council I was working on, we were serving 62% Latino families here in Los Angeles, and yet our advisory board didn't have any Latino representation or second language representation. And so I went to a support group in the community. It was just a bunch of parents, Spanish-speaking parents who were coming together to support one another while they raised kids with special health care needs. Not really different from the support group I was going to, right? But by going out and getting to know that support group and then inviting them to join us in this effort, we were able to look at the challenges of bringing together multiple languages into a single meeting and leverage resources that they had, that we had, to bring it all together. So when you're thinking about, gosh, how am I going to do this on my research team, have a focus group, go out into the community, have a couple conversations about how you might be able to connect that so that you're not feeling like you have to come up with a solution yourself. All right. Did I capture everything in the chat box in the Q&A?
I think so.
Okay, great. All right. Next slide, please. So when can stakeholders engage in research? So I saw someone had a letter of support. So that's pretty far upstream, right? To have patients and families involved in even applying for the funding source. That's fantastic. I hope that along with that, they're having the opportunity to influence the study itself and maybe even the study design. And I want to, I'm picking my words really carefully, and I think that's important for researchers to understand that this isn't me as a patient and family member coming in and directing you how to do your study, because I don't understand everything that you went to school so many years to understand in terms of, you know, validity and feasibility and all of those areas. It's a chance for me to influence based on my lived experience. All I have is what happened to me, and this is what I experienced, and gosh, this would be really important to my family. If you could figure out how to reverse, an increased lung function, that would be the most helpful thing to my family. And so how does that relate, that opportunity to influence? The further upstream, the higher the value. And so kudos to those of you who are bringing patients and families in really early on. And I want to share the story of two different research projects that I've been involved in from my own perspective. One was the Patient Priority Care Project, and we had PFA engagement funding to really identify where are the gaps, what do we need to know to really move towards patient priorities being embedded in informing care. And so I was brought in as a co-PI, and that gave me the opportunity from the get-go to embed patient and family engagement. It gave me an opportunity from the very early pieces of the research strategy coming together to inform and influence. And in that way, the researchers on the project could use all of their expertise to design something that was very robust and would have a great opportunity to impact. And I still have this opportunity all the way through to discuss how would we build better engagement practices? How would we get to engaging folks into these meetings that would be multi-stakeholder? How could we prepare those people for partnerships so that when they came to those multi-stakeholder meetings, they had a lane and ability to influence? How could they help with getting the word out when we were finished and disseminating to broader audiences? They were involved and invested with us from the earliest days, and so all the way through, they were influencing and informing the study. Conversely, I was involved in another study around physician communication, and I was brought in to do sort of a letter of support and help, and then I really didn't have another opportunity to touch base until after the launching was, the study was funded and then it was launched, and the study model was in place. And so we would attend, and I did have an opportunity to bring some other advisors in, but we would attend the meetings and we'd look at surveys, and we'd give feedback about, well, this language might not be, it could be misconstrued this way, or it might be more strength-based if you said it this way. And then we heard from the researchers, well, those are validated surveys. We can't change the wording. So what happens there? We have this disconnect, right? We have this, well, then why am I here? Why am I spending my time? So I think the value in engaging patients and families very early on in a research study gives you better efficiency, because it helps you to line up that influence and information with the study design itself. So I think that's an important takeaway. Early and often is how patient-family engagement works best. Does that make sense in your world and with your language, Jane?
Definitely. I think speaking to your second experience, that I think oftentimes there's a mismatch between what each stakeholder, including researchers, think they should be getting out of the relationship, right? And so having really clear expectations about what each partner or each stakeholder will be contributing can sort of help mitigate that sometimes. But I agree, starting from, with the if possible, conceptualization of the research ideas or the approach with stakeholders can really have everyone on the same page and really enhance not only the efficiency but the impact and the equity approach for the research.
And one other thing I was thinking about that was that second example. Those researchers have the best of intentions and really want to engage patients and families. It really, I think it probably comes more from a stance of we don't want to impose too much on our patient and family advisors. And I hear that a lot. So I want to just dispel that one right now. Really encourage all of you to suspend your assumptions about what people will do and won't do, because you may inadvertently be limiting their ability to engage with you. As I said, I've been an advisor since the mid-90s, and 70% of that has been volunteerism, because I'm so passionate about improving the healthcare system for the next family that comes through it. And there's a lot of people like me. I'm not that unique. So, suspend your assumptions and don't worry too much about putting on your advisors. Give them plenty of opportunities to give you that feedback. This is as much as I can do right now, but don't inhibit yourself from reaching out to people by making an assumption about what they're able to do or willing to do.
I think also, but be clear what you like them to do.
Yes, absolutely. That clarity is critical, right? Because that's what brings us together. If we have a really strong vision and a really strong North Star, then all those stakeholders can come together under that one North Star, and we're moving together towards it, but from our unique perspective.
Exactly. Should we move to the next slide?
Yep.
And so, Libby, you've shared a lot of experiences already that kind of fall on this diagram, but I like this diagram because it gives us a visualization of how on the x-axis the number of stakeholders as it increases, and on the y-axis the extent of engagement. And then you've been co-PI on a research leading this is patient community-driven research where the extent of engagement is very high, but there are fewer because there's fewer PIs. And then we go to research partners or team members, which maybe you've done also as well. And I've had research community or patients be part of the research team in terms of making key decisions, helping with recruitment, helping with data analysis and things like that. Do you have anything else to add in that aspect?
Yeah, I really like this graph. Thank you for introducing it to me. And I think it sort of speak to the idea that the more touch points we have, the more engagement opportunities we have with patients and families, the more value they're going to bring to the research. So, you know, it's, again, not this or that, but rather moving through all of these activities and engaging patients and families along the way, I think is the opportunity for the highest value. And so I guess I have participated in each of these engagement opportunities that you see in the darker triangle there, and have learned a few things about how I feel like I'm more effective and less effective in each of those things. And so I'm going to really focus on that governance and advisory groups, because I think a lot of people are interested in how we create effective advisory groups for research teams. And so what we've learned in our 10 years of setting up advisory programs, and we're really moving to programs aside from councils, right? That was kind of the first iteration, was everybody setting up councils, and that is still a really great model for it. But as we spoke about before, we have to be a little bit more flexible than just that kind of once a month convening or what that looks like, and really expand our thinking about how that can look. So if we're expanding our thinking, what pieces are important to keep consistent? The need for infrastructure behind this partnership is really important, really important. When we recognize the gap between your knowledge as a researcher and my experience as a person with a lived experience, that's a pretty significant gap. So what helps us to close that and meet up with each other is that infrastructure that we put in, that strong vision and North Star that we spoke about before. Really, it illuminates for me my opportunity to contribute as much as it does provide you the focus to move research in a given direction, right? So really putting some strong infrastructure, I shouldn't say strong infrastructure, putting some solid infrastructure with the ability for flexibility built in. I know that was kind of a conundrum there, but that's really what's needed. You know, it's kind of like, Jane, when you and I were talking about this presentation, in concept and talking about it, we were, you know, kind of all over the map, right? And then we got something on paper, and we both were able to respond to what was on paper, even from our different perspectives. That helped us with the process, right?
So having something on paper or written or visual for the team to use to understand the relationship and the way they're interacting is very important.
Exactly. So that gives us a line for being, you know, lined up to the mission or the vision for the research project, and really enabling us to be effective in our role. What are the expectations for the role? What do you know, is it enough that I just have lived experience? Or were you expecting that I would have, you know, that I'd be able to travel to an in-person meeting? Well, setting those expectations up front gives everybody, again, something to respond to, something to prepare for. Preparation is absolutely key as well, and I think we're going to talk a little bit more about that in a moment. But both for the research team and for the patient-family advisor, if you guys can together create a set of common expectations for how the partnership's going to work, it gives you something to flex from, right? So if you have to flex because your format of meetings or convenings is not working, you have something to flex from versus just trying to, you know, nobody really has an expectation of how this is going to work. That's where people get frustrated. That's where people get unmotivated and drop off. So the infrastructure all the way through, from developing your vision statement, doing some intentional recruitment around what your expectations are, orienting patients and families, critically important, and then planning really intentionally about how you will work together. Those are the infrastructure pieces. So I just wanted to kind of highlight that, because I think, you know, again, with the best of intentions, sometimes we grab patients and families that fit sort of the mold of what we think we are looking for, and bringing them in. But then I can't tell you how many times I've seen this. in person and virtually over the phone, they all come together, and the professionals look at the patients like they're going to know what to do, and the patients look at the professionals like they're going to know what to do, and we end up with this globally awkward moment. So infrastructure is the way to avoid that.
So thank you, Libby. I also want to highlight in this diagram that the upper part focuses on ongoing involvement. So these are like more long-term relationships or a long-term grant that you have spanning over months or years, right? And maybe you've had a pre-existing relationship with them and then with partners, and you're hoping to continue that beyond the project. But there's also opportunities for those that are interested in patient and community engagement to have more short-term involvement. And it might be that you apply more human-centered design approaches to involve community members or patients in certain aspects, certain limited aspects of enhancing your research, such that it be a recruitment document that you have, or a recruitment approach, or marketing material that you have, or helping you understand some of the results or things that you're finding in your research through the lens of patients and community members. So that can be more short-term, be more a couple instances, and very time limited. The other would be, sometimes you could just conduct a survey within a patient or community population in order to get more insight in how as you develop your work or as part of your work itself.
Yeah, you're right. Those touches can be so important to informing the overall project. Absolutely. So all of these activities are very, very meaningful. All of them build on one another and should be connected, again, through that infrastructure. So how are the surveys and online polling informing the sort of advisory programs? Are those advisors getting that information, and how does that move forward more deeply into your research project? Does that make sense, how you kind of connect all of these pieces? And I should say, in the patient priority care, we created a concentric circles, and they were all related. So we made that intention to connect all of those points of engagement. I think that can be really a robust model. It sounds like a lot, but it really just kind of naturally builds on itself.
I agree. Setting the intention initially, even if it's just a few moments, can really increase the impact and improve the efficiency of the interaction.
Yeah, and I think for those of you who are starting out with engagement, I think there's tremendous value to starting at any of these levels, but especially with, like you said, some of those human-centered design activities really will demonstrate to your research team the incredible untapped resource that the patient-family perspective brings to your work. So those are great starting points, or if you're working on a team or at a center where you're still sort of building that leadership will for this engagement piece, and you've got some folks that are maybe a little hesitant, those are some great starting points.
I think we can move to the next slide.
Yes. All right. So elements of impactful advisory efforts. So this slide is really a compilation of not only our own experiences as advisors over the last 25 years, but also we have a community of over 600 patient-family advisors from across the country that are involved in all the activities that were mentioned earlier within the health system, the greater health system. And we depend on our PFA network to keep us informed on the changing landscape of advisory efforts, and by changing, I mean the strengthening and diving into new and different activities. So when I share these, they're not just from me, but they're from a very large network of advisors, of very experienced advisors, some of whom we have on the call today. So glad to see you here. So just a kind of a comparison, when we're being very high impact, we have a reciprocal relationship, right? So I get the wonderful privilege of working with the Aging Initiative and working with Catherine and all the folks involved in this. I'm sorry, I cannot remember names to save my life. Leah and Heather and everybody else. we have a reciprocal relationship, right? I bring forward ideas, they respond to them, they bring forward ideas, we respond. It's this ongoing reciprocity. A little lower impact is a very customer service approach. And while that customer service term probably doesn't resonate so much with researchers, it is an approach that I referred to a little bit earlier in terms of let's bring our patients in, we'll give them a great meal, we'll, we really want them to be happy in this partnership. We want them to, we're really honored by their presence. While all of that may be true, what we really desire is that reciprocal conversation. So when we get too far down the line with customer service, it can feel like tokenism. It can feel like, okay, here I'm in the room because they, wanted to sort of check that box. And you may really want my ideas on how to improve the patient experience overall, and that can be great. But if we limit it to only a patient experience sort of approach, or we really limit the impact of the advisors to be able to comment on your overall project and how it might be disseminated, how it might be understood by the patients you're trying to recruit into your research project. So that reciprocity is really important. When it's tied to the goals of the study, when that patient-family engagement is directly influencing the goals of the study, that is when we really feel invested. We feel like we're embedded in your project with you. When it lacks that anchor, when we lack that North Star, we really kind of have a diluted approach to patient-family engagement, and the value is diluted because we're not really sure how we're influencing the study, right? So in that second example I gave, and from my own personal experience, I'm not feeling as invested in that because I'm not sure how I'm really influencing it or where my opportunity is. So it's kind of this murky water. Having a North Star, having that infrastructure that directly ties my efforts to your goals is really a high impact approach. Being proactive, I think this is probably the thing that I've seen over the last 5 years as patient-family engagement has emerged as that overarching strategy. The further upstream we can get, the further we can be proactive. So we're past the point of review and revise. Yes, those activities are important, but we're moving up further thanks to human-centered design in a lot of ways to true co-design. How are we influencing how things get set up? And here's the other thing about review and revise. That limits our ability to be efficient, right? So if your study team designs something and then you take it to the advisory council, they review it, revise it, you take it back to the study team, and you have to implement and decide what you're going to implement or not implement. That becomes a very cumbersome, layered process. Whereas if you bring patients and families upstream, you have them as a continuous feed rather than feedback. We've moved them into the feed of the research project. I've talked about vision and mission as a North Star because we are speaking different languages, and I mean that metaphorically as well as linguistically. It's so important to have that North Star that we're kind of committed to together. So that's our point of connection, and really important to have that. And with a lot of the advisory programs we start and we'll have that posted on the wall in a meeting or virtually in the chat box all the time, so that that North Star is constantly present, so that we know if we're, responding to a question, we're lining up to that North Star. When we don't have that is when we get answers or responses that are really off topic and out of the lane. But if we don't have a North Star, then we don't know where that is. So really important for us to be able to be effective in your research project, for us to understand the goals of that. This always sounds so funny when I say it, but if we focus on the people that we're engaging, we're going to have a shaky structure. If we focus on the engagement structure, the people will come. What I know about patient-family advisors is that we're there because we're patients and families and family caregivers. And lots of times life gets in the way. So we may not be able to, with our most committed souls, be able to finish a project. If we've got the infrastructure in place, then it becomes about the people. It becomes about the structure. It becomes about the project, right? And so we want to engage people. We want to support people in that engagement. But if we have shift, and shift does happen, then we can respond because we've got the structure there. When I was the chair of the Parent Advisory Board at my kids' children's hospital, I was the chair for 10 years, which is a terrible idea. Don't ever do that. But what happened when I left? It all fell apart because I hadn't put the infrastructure in. So I learned this really firsthand the hard way. Really important to put that infrastructure in. And then reflective of the population that you're studying. Lack of diversity, I shared my experience with it before, but it's a current experience all the time. I mentioned that network of 600. We do not have the diversity profile of the United States in that network. It's lopsided, and we've got to work really hard to build equity into the PFA network. So do all of you when you're building into your research projects as well. Jane, is there anything else that you might add from your perspective, having engaged patients and families in your research?
I think this is a really exhaustive list. I do think the first one that you indicate here, reciprocal, is really important, where everyone in the room wants to feel valued for their knowledge and expertise, whichever fashion it came from, whether from lots of education or from a lot of lived experience. They're both equally valuable, and people want to feel that everyone wants to feel that their contribution is important. So I think that's essential to having a successful engagement. Yeah, and the other thing we've emphasized it so many times already, but having a shared vision and mission. From some of my experiences, some of my less successful stakeholder engagement experiences have been from when there was a mismatch in what our shared value or shared goal was. It might be the case. It might be the case that certain community organizations that acknowledge there are a lot of health issues within their communities, and it is a priority. But there are other pre-existing priorities that may be more pressing at that time, be it fundability or sustainability or other things that are occurring to that community that take precedence over that. And so I think that doesn't mean the partnership will never be successful. It just means the timing at that time isn't right, and then revisiting that or kind of putting on the back burner and exploring other sort of options that may be there. So sometimes when you find an initial partner, you think it's all going to work out, but sometimes there's a mismatch in sort of what the needs are or the timing of that partnership.
That's such a good point, and it's exactly why you do the work to build the infrastructure and set expectations. Even at the outset, and even if those turn out not to be the same set of expectations you'll have moving forward, I think it's really important, and this is another area where I think research teams are hesitant, but your study goals, your purposes, you're bringing engagement in to meet that goal, the North Star, right? So over time, we know that patients and families will influence maybe what your goals are, but initially, that's where the partnership opportunity exists. So really important, I think, to have that really clear. I think, where we lose a lot of folks is they'll create an advisory program and then say, okay, what do you think we should be working on? And while that can work with a lot of infrastructure built around it and some guardrails on it, mostly what that does is line you up for exactly that mismatch you just talked about, because if you're asking me a wide open question, I'm going to give you a wide open response. I'm not, hemmed in by anything other than my experience. So then we end up with suggestions and ideas that are great ideas, but not within the constructs of that research project. It becomes that source of frustration, right?
Definitely.
Yeah.
And I'll also add that I think reflective of the population studied is very important. In much of research, there are challenges to recruit those that don't speak the same language or have different cultural or racial ethnic backgrounds. And so looking into the population which you're serving or hoping to serve trying to really recruit a population that reflects that and engage patients and community partners that have that reflect that are essential. I think it's good science. It promotes values of equity. So I can't emphasize that. Yeah, it's a very important part of research.
Agreed.
So I think we have time for another poll.
So we wanted to, sorry.
Go ahead.
We realize that this is still an emerging practice, right, to engage patients and families. And so we wanted to find out what, from all of you on the call today, what's your biggest fear or challenge in engaging patients in research? And it's a little bit different than the forces driving against it, but what do you imagine is going to, if this goes terribly wrong, what does that look like? What are things that you're concerned about? Is it that you're going to have difficulty finding patients, the funding we've talked a little bit about? What are some of the other things that we're not even thinking about today? Let us know what your fears are. Jane, when you were getting started with engaging patients and families in your research, what fears did you have about it?
I had a fear that they wouldn't take me seriously.
Really?
I think, because I think I was, I still consider myself a junior investigator, but I would say, sometimes if you're working in certain communities where being older or appearing a certain way or being a certain gender may be important, right? And so I felt that maybe I wouldn't be taken seriously. I've also worked in communities that are dissimilar to my family's from Taiwan and I speak Mandarin, but much of my early work was among Filipino communities, both in Chicago and in San Francisco. And it did come up periodically that, I wasn't the right person to be perhaps, being the face of the certain organization or the research that we were leading because I wasn't ethnically concordant with them. And so I think those are very logistical, those are real logistical challenges, right? Understanding the community and the patients you're working with and working with that. And it was hard not to take it personally, and I don't now reflecting on it, but it's building that team where you have the cultural and language capacity to do the work, sometimes these attitudes, come from have a historical point of view or historical perspective. And this project's not going to overcome all of those, but acknowledging that and then working around that, I think builds a better partnership. So that was one thing I was worried about when I first started out.
Wow, that is not something that would have been on my radar. I think, as an advisor joining research groups, it was always sort of the other way around, that I would be worried that, I wouldn't be taken seriously or be able to contribute to folks that are so well educated and so focused. That's just learn something new every day. My goodness. A good reason.
We're not so different, right? Then. We're not so different.
Exactly. Exactly. I have conversations regularly with advisors as we're preparing them for partnership. And, one such example recently in terms of an advisor really trying to understand data and the way that it was manipulated. And she was getting really anxious about it because she was feeling like she wasn't, getting to where the healthcare partner wanted her to be. And in fact, the healthcare partner was very much appreciative of just even the effort. And I was saying to her, and I say to many advisors all the time, your lived experience is enough. That's of value. That's your unique value, and that's what isn't available currently. So that's just, not so very different at all.
Let's look at the poll results here.
Yes.
So I can see our active participation has dropped off a little bit.
Yep.
But that's okay. The most common fear or challenge was difficult to allocate funding for patient engagement, and then followed by I don't know how to find patient advisors. and then how to incorporate. And then there were some comments. I don't know if we can pull those up now.
Some comments on the polling?
In the chat, there was like 3 chat.
In the chat. Oh. So in terms of the funding, I think, the research world it runs so tight on the funding and makes every penny count. So I can see where that's going to be a continuous area of concern. And I guess all I can offer is a little bit of a historical and futuristic thinking. Historically, patients and families haven't been compensated for a lot of these activities, and so the more that we can move forward, the deeper the partnership. And what I see is that oftentimes in those initial areas of engagement where patients and families are engaging in research, and let's face it, it started in 2010, so it's not a very old way of doing things, and we learned so much together about how engagement works, and it's been slower to influence the funding streams, quite frankly. And in my futuristic thinking, I think that until we get patient-family engagement into the budget and the line items of all of our healthcare activities, that's where we're going to really see us make some movement on equity of engagement and move forward on this is just the way we do business, right? So I hear your challenge, but I think the more of as the funders require engagement, right, they're going to have to require in the funding streams as well. Does that make sense? Is what you're saying?
I think that I agree with that there hasn't been the shift in terms of the funding agencies to fund this more, and I think as this continues to become an important aspect of our research, it will hopefully become so. At least I can offer some practical insight, at least in our research group, when we have pilot projects and we're very transparent that we're only able to offer a certain amount of funding for a certain engagement. And if our values and mission are aligned, sometimes community partners and patients are willing to do that. And then when we have the next grant or the next project where there's a larger budget, that's where we're able to be able to fund more generously given the initial investment that may not be well funded.
I see. So you're taking almost a stepwise approach? Is that what I heard?
Well, more that we try to build an understanding with the community or patient partners that this is what we're able to offer initially, but when if we work together and we're able to, and we share the same goals and we're able to move this work forward with our next grant, that's where the return, or they'll be funded for their work, but that's where the larger budget, even though that even itself is sort of limited in scope too.
I see. So going into the chat box, I see Janice has a couple of, and I know Janice is a very experienced advisor who participates in research. The actual staffing necessary to educate fresh faces on research and how to better engage can be greater than expected. Yeah, and it's the other part of that is it's a little unknown what the norms are, right? How do you price these activities? It's a little bit difficult, I think, to get our arms around. So the more that we have forums like this where we can share those kind of standards and norms, the more we can move into that space. I don't know. How do you manage that piece, Jane?
In terms of the staffing?
Yeah, in terms of the allocating staff time to manage, like Catherine and Chris have done an amazing job in the Aging Initiative to work with the onboarding the advisors. How do you manage that staff time?
So I think we simply have to make it a priority. I think a lot of my work involves certain community partners and patient partners already, and so it may be that in order to engage certain partners that have that only speak Chinese or only speak Spanish, that you do need to have dedicated staff to do that. And I think it's an investment on our end. I oftentimes am able to achieve this by working with my colleagues here at UCSF that have similar projects that have similar needs, and then we collaboratively build those relationships together. And so then it's that I'm not trying to support someone solely on my own, but that way I'm able to recruit. We can recruit research team members that reflect the population we're trying to study, that are language and ethnically concordant, and then financially fund their support for a duration for the project.
That's a really interesting idea, like almost starting a patient-family engaged network by active center.
Yeah.
Some of those activities. That would be it. Interesting. You know, where it became a resource to all the researchers at a given center who were working within that community.
And I think there's some, I mean, we'll touch upon this on the next slide a little bit, but for some institutions that have the clinical translational science institutes, there may be already existing infrastructure where the academic institution has individuals within that institution that have partnerships or strong stakeholder relationships with different organizations or patient groups. And so that is one way to sort of leverage that resource to address sort of staffing needs and or, you know, making the initial ask or making that initial connection with an organization. And so I'll pause. Should we go through the rest of the questions or run through this slide?
We could do the questions.
Okay, let's see.
Others, go ahead.
So the next question was, to budget ahead of time is a big unknown. Engaging patients before a grant, even funded, is important, though not funded too. Yeah, this is a tremendous challenge where it's important to engage patients and community members before the grant is placed, but then there's this mismatch, right, where there may be limited funding at that time. And that is something that I think needs a structural change, right, in terms of funding mechanisms or grants that allow for planning for research partnerships. I've seen some of those from NIH institutes, but they're not necessarily the norm. So yeah, certainly that's a big challenge. I don't know if you have anything else to add about that, Libby.
Yeah, I think it is a big challenge, and I don't think we have a great workaround right now because of the way the process is going at the moment. But as you said before, I'm hopeful that as we engage further upstream, we prove value at that upstream source, and then perhaps there's some, unique kind of bridging that occurs. But I think there's a lot of folks that are willing to be invested with you in the process of securing funding.
And then for the final comment that we see here, the comment is, it might not just be funding for patients to participate, but funding to create infrastructure, right? Staffing, capacity. It would help to understand our organization values, patient engagement, just my 2 cents. And I would say that that's essential. I'm part of right now at UCSF, the diversity cohorts, which is an institutional commitment made by the chancellor to engage 4 community partners from the Chinese, African American, and Latinx community in San Francisco. San Francisco is a unique part of the country where we're majority minority, a lot of wealth in many areas, but also a lot of not a lot of wealth in certain areas too, and the disparities are becoming more and more prominent, especially as a lot of companies are here in San Francisco. And so I think I'm lucky to work at an institution where we've now made a commitment to be an anchor institution here in San Francisco to understand ways of how we affect the social economic structure here and how we can engage communities or neighborhoods that have been left behind. And so I think if certain academic organizations or universities have sort of this movement, sort of have this priority, that could make stakeholder and patient engagement be a priority, and there could be more resources within your institution to do so. So I'll go ahead and continue on with this slide. We've touched upon a lot of these aspects today during the webinar. Engaging early as possible where the impact is highest. So we do acknowledge there are challenges in terms of funding and time that could be a contributing process. I think essential is identifying common goals and values, which can set the tone for a successful partnership, and then that's sort of the North Star everyone refers to in terms of the work that we're doing, and to resolve any potential conflicts that might be there. The next is clear expectations from stakeholders. So we touched upon a little bit of this, Libby, and I think you've created MOUs in partnership, or even a charter where there's common language. In the group I've recently been, we called it epic success, and then what each person's expectations were. And then adequate preparation. So I think this is on both sides, both for the researchers as well as the patient community partners, where there's orientation, training. If there's a bunch of medical acronyms that are going to be used, what do they mean, right? Resources available for all those things. And I think even from the researcher's point of view, understanding, where the patients, what patients, if they're coming from an organization, what the history of the organization is. So having that background knowledge, so we all can, meet at the table and share and meet at the table and value each other's insights. And I think we'll touch upon this a little bit in the next slide, but prioritizing clear and strength-focused communication, not also looking at severity, but looking at resilience, looking at what this makes patients experience this illness. How do those that persevere or have very good health outcomes? What were those elements, right? Or what are the elements of their lived experiences that are so valuable that all that research and education can't teach us, right? And then lastly, we touched upon this, leveraging established networks and groups and resources. So the CTSI at your local or nearby institution may be a huge resource. Here at UCSF, we have a community engaged arm where they offer consultation if you're interested in trying to engage with a certain community or a certain patient group that can offer or introduce you to someone that may already have some relationship that can offer an entree into that community. The other might be CDC Prevention Research Centers, which conduct pilot grants, particularly with community partners, so that could be a resource in your area. And the next are patient-family advisory councils in clinical settings. Many, at least where I work, this was a priority, especially as we became a patient-centered medical home. And so there may be existing infrastructure already where you don't have to create your own council. There may be ones already where you can access and utilize for the purposes of your work. And then, Abby, Libby, you want to add a little bit more about the PFA network?
Sure. So as I mentioned, the PFA network currently consists of over 600 experienced patient-family advisors who receive through the network some peer support in the role of advisor, training opportunities. The network really informs itself of upcoming opportunities to engage and as well as skills development and the opportunity to participate in webinars or what have you to continue to build our overall capacity to partner across the healthcare activities, including, of course, research, and that's quite a focus for the PFA network. So if you are, recruiting for advisors in a given area, we're happy to put that message out to folks in that region if that's helpful to you. All right. So we've been talking about, on the next slide, if you would, we've been talking about a lot of great resources. I mean, that was such a fantastic list, Jane, that a great starting point for moving this engagement forward and really identifying, be really clear about what resources are available to you. I would encourage you as you're beginning, and that may not be at the beginning of your research project, but wherever you are today, diving in and doing a bit of an environmental scan of your community and figuring out, what are those community-based organizations that may be able to partner with you? What does your academic center have in terms of an advisory council or other community relations that you could leverage? Are there pilot funding sources where you could tap into that to really set up your study? So I'm really doing a kind of an environmental scan of resources that could help you with engagement specifically. And then the identified scope. How are you engaging patients and families? What is the scope of your program, of your project? And being really clear about that and getting some very clear phrases about what your scope is critically important. So it begins to set those expectations and those guardrails on our partnership when I know where the scope is. So that might be for a research project for patients with MS. That's your scope. Great, I know what it is. I may not be appropriate for that one, but I maybe know somebody who is, right? Versus if you are doing a research project on patient-reported outcomes and how we're going to capture those, that I could inform. So you being clear about your scope and your opportunity for us to inform is really helpful. And then that's a little bit different than the vision. So where do we want to go together? What are we trying to create? What are we trying to learn together? And being very clear and consistent in that messaging. Consistency is the other part of communication, right? We've got a clear vision. Let's be consistent with how we describe it. And that consistency helps both the team members and the patients and families that you're engaging to, again, start to build that relationship and that partnership. Recruit broadly. So I think a lot of folks, first instinct is to go to people they know or go to people they're comfortable with. And I would really encourage you to kind of challenge yourself to recruit broadly from your community or for the community that matches the scope of your work. So you can see how this kind of builds on itself. When you recruit broadly and you give yourself time to have an application process, do an interview, you give yourself a few more touch points with people before you come together to commit to this work together. So recruit broadly and allow a process of, defining mutual expectations to allow people to self-select out of your project because it's not what maybe they thought it was, and also gives the team the opportunity to make sure that we've got not only the right people, but we also have a right composite, right, that's reflective of the population that you're studying. Next slide, please. So we've talked a little bit about preparation. What does that look like? For the study team, the vision is that North Star for everybody, right? So building on that, then really being clear with the team, what's the purpose for engagement? Why are we bringing patients and families into this research project? It's so much easier not to, right? It really is. We don't have to worry about those funding things or staffing time or whatnot. So what's the value proposition of engaging and really being clear with the study team about that? Expectations, and for a long time, engaging patients and families, expectations was kind of almost a dirty word, if you will, because nobody wanted to put expectations on patients and families that were giving their time. And I understand that, but the reality is that as we set expectations, it increases the confidence of the study team to move forward in that partnership. And at the same time, for advisors, it gives us confidence that we know we're responding and partnering in a way that's going to provide value to the study team. So I think letting the study team know what those mutual expectations are is really beneficial in increasing their confidence to partner. Also sharing with the study team how the advisors are going to be prepared for this specific partnership. There needs to be that preparation for advisors to understand the context of your research program. And then finally, I always give healthcare staff members the opportunity to express their concerns about the partnership. What do they fear about this? What are they concerned about things that can go wrong? And having that opportunity to really talk through those, I find in most cases sort of quells that. And if nothing else, then I go to a time limited. Okay, let's try it for 2 months, and if we're not seeing the value out of it, we can revisit this opportunity to engage. So, but providing that chance to voice their concerns, I think, is really important. And then for the can you go back just real quick? Thanks. So the advisor, again, we need context. Context is everything. It gives us our value. So give us some preparation about your organization, about the, that should say, research team, and then about the advisory, again, using those expectations. So it's not so very different, but at the same time, we need the context of your project to really influence it in a valuable way. Next slide, please. Using strengths-based language, I'm not going to read these to you. You have the very well able to read. But it's being intentional with your language. Being intentional with your language opens the door for partnership and really sets the stage for strength-based partnership. So building on opportunities to improve versus, problems. Our entire health system is predicated on what is the problem. And that is a very limited view on partnership in these endeavors across research. So really building on a strength-based language and looking at, it can even be an activity, it can be an early team building activity for the advisors and the researchers to think together about how we could change some of the language and really flip to what are all things possible versus what are all our barriers and problems that we're trying to solve. Does that make sense, Jane, or is that really kind of challenging the research model?
I think maybe it's challenging a little bit the research model, because I think the research model is very focused on, being PI and what do we find and do we publish, right? And I mean, ultimately, research, we acknowledge, right? We want to improve health and address problems, right? Or address inefficiencies, right? But I think there is more of a shift. I think especially when we recognize patients' lived experience, everyone's lived experience right now is very unique. There's a lot of things going on in the world that don't seem right? And so wanting to really understand and empower people to attain the best health, I think, is the crux of everything. But I think we just need to be able to better translate that into research. Yeah. So we have
more to work on.
What did you say?
I said more to work on.
More to work on. That's right. So we're going to, if it's okay, we're going to the last slide since we have 3 minutes left remaining on the webinar. And Libby, please feel free to jump in at any time. And so we've touched upon a lot of these elements throughout the webinar, but partnering with diverse patients and families, especially those that are in your immediate community, can really enhance your research, promote equity, and also simply it's just good science. One element is sharing power, just like we've shared the microphone for today's webinar. You don't always have to be the loudest voice in the room, and listening is a very important aspect of engagement, so that's one thing. We've touched upon compensation at many different times. I think it's a solution that is a structural barrier that we need, I don't know if I have any other real world tips or perspectives to offer on that, but certainly do compensate stakeholders that are engaging in research for their time and their expertise. Next would be flexibility about where and when to meet. And so this may be that your patients have responsibilities during the day, they have jobs, or they have family caregiving responsibilities, where they need to meet on weekends or evenings, which may be outside of the regular hours where we conduct research meetings. And so that may be one area to help promote a successful engagement. And I think one thing would be, and I've really learned through a lot of my experiences, would be investing in relationships long term. One of the greatest gratitudes I get from a clinician is patients see me as a person too, and not just their doctor. And so I think in these sort of relationships, we have to first we come to the table both as human beings, right? And then we come together because we have a shared goal or mission. And then we put on our other hats, right? So I think investing in that relationship can really help the partnership for that particular project. But moving forward, you may come up together with some new ideas or new directions that you want to collaborate, and I think that's really exciting. And then next would be to be humble. And I think sometimes in the research world, we're expected to become experts in a certain area or know everything about something. And that's really tiresome. I don't even know if it's fully attainable. And so I think, acknowledging that what we know, but there are a lot of other things we don't know, and patients and families and community partners offer a lot of expertise and lived experiences that are so invaluable that we otherwise wouldn't know. And in preparations, as Libby had mentioned, it's a freedom not to have to know everything, right?
Yes, definitely. And I think that's, a freedom that researchers can embrace, to not have all the answers. Obviously, that's the foundation of research, right? You don't have all the answers. Embrace that and problem solve with, not for.
Exactly. And then next here, I think this would be working with certain minority or underserved populations where acknowledging the history of structural institutional barriers. And I bring this up because in my diversity cohort work, we've worked, a lot of our community partners are led by the community partners that have higher degrees. They used to work in academia to some degree and then left academia to work in the community. And so from them, they had a lot of perspectives of bias or discrimination to them or to other parts of their community. And so I think that's important to acknowledge, and sometimes we skirt around those things, but acknowledge and have a dialogue about that if it's necessary to move forward. It's difficult, but as the next item says, any problem or challenge in engagement is an opportunity for change, and I would say for positive change, right? And this is an element to question and address what are the paradigms that we're sort of confined in that we think we need to operate in, whether it's traditional research paradigm or institutional. And, sometimes when we work together, we could potentially, work towards addressing this. So here at UCSF, there are efforts to really institutionalize some of the positive changes we've made through the Diverse eCohorts project to make it more accessible to researchers, right? To have the funding support necessary to support our community partners to do the work and offer their expertise as they do. And so I feel hopeful in that we're heading the right direction, and there's some momentum in that direction.
Absolutely. Well, go ahead to the next slide.
So if there was time, we were going to talk a little bit about who should sort of decide these questions, but given that we're a little bit over now, we can table that. And then we have some resources here that when the slides are made available after the webinar, that could be helpful. And we have a final poll for today for those that remain. And Libby, I've really enjoyed giving the webinar for you. Your expertise is unparalleled. I feel that you know much more than I do.
I apologize for running us over. I think that's me and my passion run out my mouth a lot, but just so excited to be partnered with you, Jane, and with the Aging Initiative, and opening space for more and more patients and families to get involved in this. And I'm delighted to be a resource to all of you, and we've got many other resources as well. So it's exciting to be thinking about and working with you. So it's been such a pleasure to work with you on it. Thank you, Jane.
Yes, I've enjoyed it as well, Libby. I think, if there's ever opportunities for us to collaborate together, it'd be wonderful.
Absolutely.
Well, hi, this is Leah Hanson. Heather and I just wanted to thank you both, Libby and Jane, for such an excellent presentation. We really appreciate the extra opportunities for engagement and your partnership in approaching this topic together. Thank you so much. We also want to thank everyone for attending today's webinar. As you mentioned, there will be a recording of the webinar. Will be posted soon on the Aging Initiative website, and there'll be a link sent out for that. And as you sign off, we're going to ask you to complete just a brief survey regarding any thoughts or opinions you had about today's webinar. We'd really appreciate hearing your thoughts. I just wanted to thank everyone for sticking with us till a few minutes past our time, and hope everyone has a great rest of your day.